I'll now request Dr. Lalit Verma sir to talk upon interface disorders. We had just very briefly touched upon it in the OCD talk, but I think it this is a topic that requires a lot more detail, and I request sir to elucidate.
At the outset, must thank Ajanta for having us all together in this for this very nice interactive symposium. So, as Abhishek was talking about OCT, so I on the same lines divide retinal pathology into inner retina and outer retina. Inner retina means from ILM to ELM, and outer retina means from ELM to RPE. And once we are interpreting OCT, as Abhishek rightly said, start always from vitreous. That is, VR interface. I'll be talking basically about interface pathologies. I'll not be touching about other retinal pathologies at all. Remember, all of us are born with 100% gel vitreous, which is consistency of a white of an egg, a lacy substance. And with age and other diseases like trauma or diabetes, two things happen. One is vitreous gets liquefied. Second is the adhesion between the vitreous and the ILM they reduces. And if both of them occur completely and concurrently, we get total PVD. And sometimes HST or flash and floaters can occur in such conditions. However, if vitreous gets liquefied but adhesions are still present, this may allow liquid vitreous to seep behind, and this initiates the process of PVD. And this can get complicated, with cells proliferation and membrane formation and all. This is what is known as anomalous PVD or incomplete kind of PVD, and this is responsible for a whole lot of conditions which I'm going to discuss. So this is latest classification of VMA, VMT, and macular hole. And the only reason I put this slide here of was that they classify macular hole into small, medium, and large. But in our practices, I think everybody will agree, we rarely get large. We get XL or XSL kind of macular holes of 1,000 and beyond microns. So VMA, VMT, and macular hole. VMA is by and large a pathology which does not produce any symptoms at all. So if patient does not have symptoms, just touching the retina, it may be a variant of a normal also. So normally we do not touch VMA unless in your vertical follow-up there is evidence of traction. In VMT, there is an element of retinal pull. Retinal pull means it is distorting the photoreceptors. If the photoreceptors are getting distorted, the patient may complain of teda-meda vision or metamorphopsia, and with may develop onto CME or decreased vision also. So generally, these symptoms are usually mild and develop very, very slowly. Like this patient has 6 by 6 vision, and there's always a the findings and the clinical complaints. Sometimes patient may have acute vision loss that is because of this sensory neural detachment in the upper right corner. A lot of classifications of academic importance, Y shape, V shape, J shape, and focal and broad. The key point is how much is the area involved is around 500 or so. But what is relevant for us is do all this VMT require intervention? I think Tinku Bali touched upon this. The answer is no. We do not treat OCT. We are treating human eye. A lot of these patients have tolerable metamorphopsia. We कभी कभी टेढ़ा मेढ़ा दिखता है. Usually it is okay. कभी कभी. So we do not treat कभी कभी टेढ़ा मेढ़ा. And sometimes complete PVD can happen of its own also. So this is one example. Right eye, we operate on successful macular surgery, but this is the OCT of left eye. We in fact made the patient aware that you have some kind of VMT, but patient did not require surgery at all. So this patient we were following up. You see, it's February 16 to June, there was worsening of traction. So we motivated the patient for surgery, but before surgery, God was kind and this VMT, spontaneously regressed, and patient had recovery back to 6 and 6 also. So management of VMT is only if it is symptomatic, only if it is a disturbing metamorphosia, otherwise not at all. Remember, we are not treating this anatomy, we are treating a function of the eye. So basic aim is to remove this traction, and all of us have been doing MIVS for a long time. In came this Jetria with the hope that it will take away the bread and butter of VR surgeons, but not. This Jetria came with a big bang and went away with a big bang also primarily because it's an expensive injection, 4,000 for one injection, but more important than cost is the success rate is dismissal. Success rate is around 25% or so. So, whenever we do vitrectomy, it's one of the simplest vitrectomy to do because it's the only step required is PVD induction. And And this is the way we do it. After we do a core vitrectomy, uh, uh, classically two islands of this tricot stain, with this will form on one on the optic nerve, one on the posterior pole, and with gradual increase in the suction and eye always on the retina, you pull slightly, and most of the end point will be this signet ring formation once the it completely detaches from the surface of the optic nerve head. So this is the pre-op and post-op of the patient. You see the configuration of OCT may take time to come, but patient symptoms improve very fast. This is another patient who had a scary looking. In situation like this, you should not pull. You should do a foveal sparing kind of, pull on the retina. Otherwise, sometimes you can end up creating a iatrogenic macular hole also. So second membrane is epiretinal membrane, and as was being told by Dr. Tinku also, all epiretinal membranes don't require surgery. This patient, both eyes, right eye as well as left eye, has ERM, but both eyes are 6/6, does not require surgery at all. So whenever you do surgery, after you take care of the core vitreous and detach the hyaloid also, then I preferably stain this epidermal membrane with trypan blue and then create an edge. And once the edge is created, then the surgery becomes simpler. You tease away this epidermal membrane, which generally comes in one go, and this is the end of surgery. Normally, no gas is required, only airflow exchange is good enough. There's another patient who has ARMD, dry ARMD plus, has a significant ERM. So after you have detached the hyaloid with the help of triamcinolone, you inject few drops of trypan blue on the posterior pole after the airflow exchange, and you wash away this excess of trypan blue, and with the help of a MVR blade, try to create an edge. Once this edge is created, then take hold of Eckhart forceps, and this epidermal membrane will generally come in one go. And after that, you do an airflow exchange. So these are some color photographs pre and post epidermal membrane surgery, and this is OCT. The foveal contour starts coming back after a couple of weeks. The other patient to show the successful epidermal membrane surgery done. ILM peel is, controversial. All of us have become ILM addicts. We do try to peel ILM, but do not insist that all patients of pure ERM require ILM removal. And even global trends show that ILM peel is not necessarily advantageous. In macular hole, apart from the hyaloid, apart from the epidermal membrane, what is essential is to take away this ILM. ILM generally should be stained preferably with the BBG dye. And once that is done, you make a nick, either direct pinch and peel technique or with finish loop or with the diamond dusted scratcher like this. And once you have done this, you take this ILM across the macular. ILM peel, what we do is take the ILM across the macular hole, and this generally does the job in small, medium, and large macular holes. So this is one successful surgery here. This is another patient full macular hole closure. But a lot of things have changed. A lot of variations have come in macular hole surgery. A lot of positioning things have changed. ILM flaps have come. Retinal tissue has been used. Lens capsule has been used. This was a game changer for me. That ASRS conference in 2016, when I approached this lady with a large chronic macular hole, followed up for more than years and years. It took up for surgery, and what we did in this lady was, after the initial PVD induction, you see, instead of peeling it across, you make this flap, direct pinch and peel technique, and take it till the edge of the macula hole and leave this there. I normally at least do this multi-layered kind of ILM. I know a lot of variations are there, and a lot of discussion can happen, but this is left at the end, and with at the end you just take cutter and trim it with the largest smallest possible section, the largest possible cut rate, and this is the end result of this. Some ILM fragments are still there, but believe me, this surgery, this is another patient who had a very difficult configuration of OCT, but still resulted in closure as well as some improvement of vision. So believe me, today macular surgery has so many variations, but broadly we have peelers and non-peelers. Non-peelers means they do all crazy stuff like flap and temporal flap, or sometimes even amniotic membrane also. So if you have large macular hole, chronic macular hole, persistent, recurrent, or reopened or myopic, these are the situations where a routine ILM peel may not work, and you may have to resort to things like flap or autologous retinal transplant or even human amniotic retinal transplant also. So with this, I think the large macular holes have more propensity to close. So thus to summarize, this is the latest classification of closed classification where we divide to small, medium, large, and then XL and XXL and giant macular holes. So till the large, you can get away with ILM and ILM flap, but with very large macular holes, things like you know ART, HAM, or combo, with the help of maybe even hydrodissection, may have to be done in such patients. So thus to conclude, OCT, and OCT has helped us in understanding this newer theories of BVD, and with this staining agents to our rescue, and the small gauge vitrectomy MIBS to our rescue, the prognosis has improved even in the very chronic macular holes also. So just remember three membranes: PHF, and ERM, and ILM. With this, I think this prognosis is not so grim now as it used to be. And no patient today, believe me, whenever is required, should be denied for the opportunity to have this surgery done. Thank you so much for your attention.
Thank you so much, sir. I'd now request Dr. Arvinder to come and give his talk. Now, after any surgery, the first and foremost concern of any surgeon is the post-op inflammation. The minute you see post-op inflammation, the first thought that comes into your mind is whether it is an inflammation from the surgery or is it an infection.